afternoon, everyone. Thank you for coming. You probably don't know me. I'm Joyce Jones. I'm a clinical associate at the Moore Clinic. I'm an HIV provider, and also I'm directing the PrEP program at the Moore Clinic. And know Jeff Hitt from the Maryland State HIV Planning Group and the Baltimore City HIV Planning Group. And Jeff is the director of, and there's a lot of words in the Infectious Disease Prevention and Health Services Bureau at the Maryland Department of Health and Mental Hygiene. So he came to us in April of 2015, and he's responsible for the overall coordination of HIV, STI, and hepatitis, and viral hepatitis response efforts. He has many years working in HIV and STI epidemiology and public health, previously program associate director at the Louisiana Health Department, and then prior to that at the Texas Department of State Health Services as planner epidemiologist and manager of HIV and STD prevention.
Yes.
And we asked him to come today to do an overview of the Maryland State Plan for HIV prevention and treatment. And we thought this was a really nice opportunity to go over the state's view and the city. He's going to be representing Dr. Chalk from the Baltimore City Department about what are the needs, what's the overall landscape in terms of HIV prevention and treatment, what are the needs, and from the health department point of view, what are some strategies to impact the epidemic. So thank you so much for coming.
Well, thank you for having me. Here we go. Awesome. So as I said, I'm Jeffrey Hitt. I just celebrated my first year here in Maryland. I'm really excited to be here. Patrick Chalk was supposed to present with me, and he's out sick, but there are a number of Baltimore City Health Department people here. Raise your hand. Yay, thank you so much. So y'all chime in anytime, you want to give some of the, he was going to help me with some of the deep background around this plan. I'm really excited to be here to get more connected to Hopkins and the Center for AIDS Research, and I hope that this will start a lot of conversation that will help us move forward on HIV here in Maryland. And probably have to turn this thing on or something. Yeah, I'll just use this. Or, oh well, it's changing there.
This is insane. Okay, hold on. Oh my gosh. Let me just check something. Hold on a second.
We have this smart board in our office and at the health department, and it never works either. Like you sit there and be punching it to advance it, and nothing happens, and then you step away and it goes 3 slides forward. So, I could just describe every slide to you. It'll take a little bit longer, but not a lot. So I am going to go ahead and give you a little bit of background, and then we can catch up a little bit. The title is Planning a Comprehensive Coordinated Response to HIV for Baltimore and Maryland, and those are sort of some of my watchwords: comprehensive and coordinated response. And so we'll dig into just a little bit of what that means. And we're also doing an integrated planning process for both the state of Maryland and Baltimore, and I'll tell you why that sounds totally reasonable, but I'll tell you why that's new a little bit, and then we'll have plenty of time for questions. So just to give you really briefly, I wanted to go over a few epi slides. I haven't broken them all down for Baltimore, but just again set a little bit of context. HIV is actually going in the right direction in terms of new diagnoses. We're seeing some decreases. There's a little bit of maybe artificial bump in here from the transition to named reporting in Maryland, which happened around like 07, 08, and but in general, you can see the trend lines look pretty good. This, I hope, is not a huge surprise in terms of like we have more males infected with HIV than females than women. The race ethnicity disparity is shocking if it hadn't been going on forever. But as you can see, we've made some progress, but still quite a large difference. And then I want to spend just a little bit more time on this because I think the changes in age are pretty drastic. We can see this decrease in 40 to 49-year-olds over the past 10 years. That's been quite dramatic. What we haven't seen is much of a decrease really in 20 to 29-year-olds. So they are now the largest group of people by age who are getting infected with HIV. So that's quite a big difference from 10 years ago. And you can see that there's been this somewhat of a decrease in 30 to 39-year-olds, and even a little bit in 50 to 59-year-olds. Pretty stable here in terms of the very young, the adolescents, and 60 plus. Now, I would say that over 60 and really over 50, you're starting to see a lot of people who are diagnosed with HIV and AIDS at the same time, indicating they were infected quite a long time previously, and either may have avoided testing or had really no understanding of their risk. Risk isn't always individual, so it's sometimes hard to know if you're at risk. Speaking of risk, so here's the diagnoses by risk category. And you can see that 10 years ago, we had a very different looking epidemic. Heterosexual infections, IDU infections, and then MSM. So what's changed? This enormous decrease in injection drug users who are getting infected with HIV. A good decrease here, but then it's bumped. And so kind of interested to see where this is going. We'll be looking at 2015 preliminary data in the next month or so, and then we've actually increased the rapidity with which we're reporting data, so we should have final data. I don't know if data is ever final, but final data by mid-year, by July, August, we'll be starting to analyze 2015 data. So, what hasn't changed or has increased slightly is gay, bi, and same-gender loving men, or men who have sex with men, and that's it. By geography, you can see that improvement, huge in central area, which is Baltimore and the surrounding counties. And that's primarily Baltimore City. There's also a fair amount in Baltimore County and a little bit in Anne Arundel, but I mean it's primarily Baltimore City. And you can see we've made a great improvement in Baltimore, in the Baltimore area. Not so much this is suburban DC, so not suburban Baltimore, this is suburban DC. This is Prince George's in Montgomery County. And you can see that now, whereas it was sort of almost 2 to 1, 2 to 1 here, now it's about equal in terms of the number of diagnoses. So we have some work to do in suburban DC. So as we look at this, what's this decrease in 40 to 49-year-olds and 30 to 39-year-olds? I think it's very much connected to the decrease in injection drug users. In the past, injection drug use was usually something that people initiated fairly a little bit later in life. 30s, 40s was when they might progress to injection. Now we are seeing overdose and other information that indicate across the country that indicates that people are injecting drugs, and it's a whole new set of people, often starting pretty young. So while we're super excited about this decrease, we know we have a lot to do to make sure it stays that way. What would be the primary reason that this happened? Needle exchange, right? Yeah, and we've got that needle exchange in Baltimore, but not as much in access to it maybe in DC. in suburban DC. So talking a little bit about like where we find ourselves as a bureaucrat, as an administrator, how did we get here? Well, we have several jurisdictions. We have Maryland, Baltimore, and DC are all funded to do various types of activities around HIV, and one of those activities is planning. So there's a couple of major funding streams from HRSA. We get our care money, so that funds the AIDS Drug Assistance Program. It funds all of the medical and supportive care in Maryland and Baltimore, and that comes to the city and to both Baltimore and DC as Part A funds, and it comes to the state as Part B funds. And but it's all money, and it all pays for pretty much the same things. Although we run the AIDS Drug Assistance Program at the state for all residents of the state. And then we have money from the Centers for Disease Control for HIV prevention, testing, condom distribution, partner services, behavioral intervention, policy work. They've each had, and of course I left off here, NIH, which is what funds CFAR, is a big funding stream. I'm not really familiar with what planning structures or planning requirements NIH has put on those funds, but HRSA and CDC have a long history of planning requirements, and they're not the same, or they haven't been. And so we've had a number of planning structures. So Baltimore, for a long time, has had an HIV commission, right? And I don't have the whole history on HIV, so this is where Patrick would be filling in on the history of the commission. Planning councils is a function of HRSA Part A funds. So there's a Baltimore HIV Planning Council, there has been for a very long time. There's a DC Planning Council, there has been for a very long time. And they're supposed to give input on priorities and allocations for services. HRSA has a whole set of 20-something service categories to support people with HIV. And then the Centers for Disease Control. Oh, and then the prevention planning groups were established as a requirement from the Centers for Disease Control. And really, the history on a lot of this in terms of community input comes from ACT UP and a period of the 80s when government was not responding to HIV. And we really spent a decade not responding to HIV. And because of those protests and activism, government got involved, established the Right and White program, and started allocating CDC resources for prevention. But they had separate planning, because this is planning for prevention, and this is planning for services, and this is a local city response. So we have all these different planning structures that have grown up, and they're really attached to the funds. So like, do this planning structure for this funding. So what has changed somewhat is that we got a national strategy. First time, I think it was 2010. Was it 2010?
Yes.
Yes, 2010 that we got a national strategy, and of course we've required countries in PEPFAR, participating in PEPFAR, to have a national strategy for years and years and years, but we never had one ourselves. So that it was nice, and I think the vision from the national strategy is one that we've adopted for our planning process. And we're just going to put Maryland in here because this is probably the best thing from the strategy. I'll be honest. I mean, it's beautiful, right? Maryland will be a place where new HIV is rare, and when it does occur, everyone will have unfettered access to care. So, rare, and everyone has unfettered access to care. As we're doing our planning process, so I jumped over a couple of things about the funding structure, but so we have this national strategy. We have some overall goals, right? Reduce new infections, assure quality care, and improve health outcomes, reduce disparities and inequality, and as a bureaucrat, I think this is very important. Achieve a more coordinated response. So in some ways, we're wasting a lot of time not getting to these things because we're not getting to this. So So we have a national strategy. We've had these different funding streams, these different planning processes. But from the state of Maryland, from the state of Maryland perspective, I can't really write a plan for the state of Maryland, and we can't plan for HIV in the state of Maryland without taking Baltimore into account and without being concerned about Baltimore. So we are not just a mechanism for CDC and HRSA funds, right? We're the state health department, and we're public health officials. So we have some requirements around the funding, but we also want to write a plan that is comprehensive and addresses all the needs in Maryland. And it would be really bad if we have a city plan that contradicts a state plan, or even they just don't match up, right? So as we are looking at the national strategy, it calls for a plan. It doesn't call for a prevention or a care plan or a city plan. It calls for a plan. That has helped us get together and resolve to have one integrated product. Even though we still have several different planning structures, we're moving towards one product. So it will be a plan for Maryland, inclusive of Baltimore and suburban DC and all parts of Maryland. So that's what we're hoping. I think everybody is probably familiar with this, right? The continuum of care. It started out as the Gardner Cascade, and it was just a sort of a particular way of looking at HIV, especially in light of understanding just how important viral suppression or suppressed viral load is in terms of decreasing the chance of new infection, as well as, of course, the individual benefit of treatment and long-term viral suppression. So we got a lot of information, really, even over the last 5 years, about the effectiveness of treatment as prevention, as well as initiating treatment as early as possible for individual benefit. So it's nice that individual and public health benefit is concordant and coming together. This is a really good framework for thinking about HIV, but we think it's incomplete. And although there's a lot of focus on these 5 bars, we have expanded our continuum as we've thought about planning to back up a little bit. I'm going to back up so that y'all can finally see some of the slides. To really look at the traditional continuum starts with undiagnosed infection, but we want to back up and talk about vulnerable populations, people who are HIV negative, and we want to understand what's important to help people stay HIV negative, and then even general population. And I think it's important to have general population on here because Kaiser Family Foundation does a survey every few years about HIV. And 1 in 4 people still think that you can get HIV from drinking from the same glass after a person with HIV. So we have a huge level of ignorance around HIV transmission, and no wonder we still see a huge amount of stigma. So getting into a little bit though of the details. So we're starting with, okay, so this is our frame. This is the start of our framework. Is this expanded continuum, and undiagnosed infection, so then you get to diagnosis, linkage to care, in care, retained in care, on antiretroviral therapy, and of course achieving viral suppression. What do we mean when we say comprehensive coordinated response? So our plan needs to speak to needed activities beyond just health departments. So we're not writing a grant application or a plan for our grant funds, but for what Maryland needs to do to address HIV. So that means a broad set of people and organizations that would be important to HIV response. It means some of the policy work, some of the leveraging work that we want to do rather than trying to do it all ourselves. Coordinating and planning and implementation across jurisdictions and funders. So if you haven't figured it out yet, this is one of my big missions in life, I think, is to sort of get us beyond this sort of question of attribution and contribution. It's like, what did my money pay for? And I said, well, your money contributed to an effort that achieved, this, but we can't always I'm not sure we can always get to attribution. And if we focus on attribution too much, then we end up limiting ourselves to like what's in my jurisdiction versus yours, and my dollars versus your dollars, and these red dollars versus these blue dollars. And then comprehensive coordinated response really means stronger connections between programming at the local level. So we have some work to do on that here, and I won't spend too much time talking about that in Maryland context, but you talk about Part A funds paying for some things, Part B funds paying for some things. They're all the same services. We have different eligibility levels in terms of, some of these services are you have to be below 400% of the federal poverty level. Some of them you have to be below 300% of the federal poverty level. So there's a lot of bureaucratic coordination that we need to do for a stronger local connection, and that's really where comprehensive coordinated response is going to come together, is at the local level. Socio-ecological model, we're at Hopkins, y'all should love this, I'm sure. So we simplified it a little bit because you can draw them on a bunch of different levels and talk about it a bunch of different ways. But in the end, individuals are embedded in networks and communities, and those networks and communities are influenced by systems and institutions. And so hopefully we're taking that into account as we call out what's needed to be done, and we think about what intervention needs to be done. I think HIV work, by the way, I feel like I've been talking a long time, so if you have a question, you can shout it out whenever. I mean, we'll discuss later, but anytime. HIV work, I think, in particular, and maybe because it's, the actual act of transmission is usually not a public act, it's usually pretty private and stuff. So we focus a lot on individual and private behaviors and behavior change. Sort of like the amount of thought that's gone into how do you promote someone using a condom is impressive. But then we get to, say, a community level or a system level, and we think, well, we just need to invite Medicaid to the table, and they will do what, we ask them if we ask. And we have to think just as carefully about the decision makers who are making system and institutional decisions, what motivates them and what might encourage the behavior change that we would like to see, like funding more HIV, making HIV a money measure for, or a QI measure for a health plan or something like that. Like what's going to make that, so thinking just as deeply about how we change those systems and institutions as we do individuals. I think as we've been developing our plan, we felt like it was really important to talk about values. So the characteristics over there are sort of just repeats of what we've already talked about. It's about people, environments, and systems. It's multi-sectoral, comprehensive, multi-jurisdictional. But values, important to talk about values, harm reduction, harm reduction is a value. It's also scientific, but taking a harm reduction approach to say needle exchange is a harm reduction approach, but so is condom use, so is PrEP. It's a harm reduction approach. So is seroadaptive strategies like seropositioning. Does seropositioning make sense to y'all? Like if you're top, you're more likely to transmit, so the negative person might be a top, and or you might, anal sex is much more likely to lead to infection than oral sex or things like that. So taking a harm reduction approach, health equity. We can deliver our services to communities who are disproportionately impacted by HIV all day long. We can deliver those services to the people most impacted, and it will not change the basic disparities and inequalities because they're deeper than just HIV. I mean, if we talk about service access or poverty or housing, I mean, housing is a huge complicating factor both before, in terms of risk for infection as well as engagement in care and positive outcomes for people who are HIV infected. Self-determination, I think we spend a lot of time talking about, public health is probably one of those incredibly logical positivist fields, like we know what's right and we were going to figure out how to make you do it. But in the end, we really need to acknowledge self-determination. I think even in our language, we talk about linkage to care all the time, and we talk about how many people did we link to care. And the truth is people enter care. So I think, not that I'm going to try to change everybody's, complete usage of, like, we're going to ban the word linkage, but I mean, people choose to enter care. So for example, the revised national strategy has changed the measure for entry into care after a diagnosis, and they want to know how many people get in 30 days. It used to be 90 days, and now it's like 30 days because it's urgent, right? And you got to get that person into care. But I think we have plenty of experience that shows that people aren't always ready to jump into care and sort of and question, like, what does that entry and engagement really mean? So I'm not really a huge fan of that transition to measuring it in 30 days versus 90 days. And then sexual health promotion. How can we come from a place that is that acknowledges sex and sexuality as a part of lives, and that pleasure is an important part of life and of sex, and let's acknowledge it. I think the World Health Organization has some great definitions that we want to key off in terms of that. So, are you tired yet? I am tired. So this is the overall plan framework, and as you can see, like, rather than having sort of 9 spots on the continuum and trying to address each one as if it's separate, because even with just 5, we come up with all sorts of things that sort of cross over, and how do we deal with some of these things independently? But what are the actions in terms of general population? Heightening urgency and awareness of HIV and reducing stigma, protecting individuals and communities at highest risk, so vulnerable populations, full diagnosis. How do we get diagnosed all Marylanders living with HIV? I think reducing undiagnosed infection is one of our huge challenges. And well, I'm jumping ahead of myself. We'll get there in a second. There's only like 50 more slides. Care engagement. So care engagement, that's rather than talking about linkage separately, which is that one-time like entry into care after diagnosis, like care engagement is that first linkage. It's people move in and out of care across a lifetime. People talk all the time about, why don't people with HIV engage in care better? And it's like, well, if you look at adherence for all sorts of other diseases, diabetes or high blood pressure, high cholesterol. That's why I'm in HIV, it's easier to pronounce. But we don't see that much of a difference in terms of long-term adherence, and it starts to make a little more sense, And then, of course, viral suppression, which is really, almost more of an outcome, but, there are a few specific things that we want to talk about in terms of, okay, you're in care, but are we really achieving viral suppression for everyone, who can and who's ready? So there's a whole lot of blank space on this because we cut some things. These are as we've done a number of engagements. We have previous plans to look at, some research, not enough. We haven't synthesized enough of the research, so maybe y'all can help us with that. But over time, over the past 6 months or so, we've been developing input and trying to coalesce those things into strategies. And then at our statewide HIV planning group, so I'm still using the old language, we've merged our care planning and our prevention planning. So we got one step towards a more integrated body and product. But we did some prioritization work with them, and then the city has done some prioritization work with, and especially the Party Planning Council has done a lot of input sessions to get some more detail. And I'm giving you like the really highlights. There's a lot of detail behind this in terms of how to do it, but we'll talk a little bit about it. So community mobilization has come up as one of these major things that we can do for general population, and it's really things like training around around advocacy and helping local practitioners identify advocates who can carry our message further. One of the main ones that we've talked about, of course, is sex education in schools, and in 3 different states now, I'd say I've had the experience where we talk about that, and we have all sorts of sexual health advocates saying, we need to get the Department of Education to do this. Well, it's not going to happen at the Department of Education, I can tell you. It's going to happen locally, and there's in fact a ton of local control over schools. There are school health advisory boards, there are PTA, there are school boards and principals, and those are really the targets for action. And we're really taking that socio-ecological model to heart when we talk about this, because this is not about getting access to go give 7th graders a talk about sex and STDs. It's about getting the schools to do it. So, how do you get a bunch of people to get sex ed without being there, right? Marketing for general awareness. There's a lot of marketing around HIV, but it's usually an exhortation to test. There's some more and more stuff about getting into care. It's usually pretty focused on vulnerable populations or people most impacted by HIV. It's been a long time since the Surgeon General, C. Everett Koop, sent a brochure on HIV to every household in America. We haven't costed it out for what it would take to send that to every Marylander, but certainly something on on that order, or something that talks about overall stigma and awareness, we think is warranted. Now, again, we're talking about strategies that are needed for this effort. So it's not always what we can pay for. Sometimes we're making some recommendations for other people to pay for this. So. Which I think is difficult. I talked about attribution and contribution a little bit earlier because it's one of my pet peeves. But everybody comes into this work wanting to pay for things that are easily measurable, because we have a bias towards the easily measurable. So certainly you can measure this, but it takes quite a while, and it takes a big random survey. So it's a little bit tricky, I think, to get support for that. And then you can't really, you can't do a randomized controlled trial to say it was this message and not that message that really did it, and it wasn't my dollar or your dollar, Anyway, I'll get off my soapbox for a second. So we have quite a bit more in terms, as we start talking about vulnerable populations, then, and one thing we haven't named a laundry list of vulnerable populations, but you saw who's impacted. I mean, it's gay, bi, and same gender loving men, and it's especially young African American, gay, bi, and same gender loving men. It's African Americans in general. I think although injection drug user infections have gone way down, the evidence we have that shows the increases in injection drug use just shows us that Indiana could happen almost anywhere. So Indiana's where the big outbreak, right, of HIV happened in a very small town. I think they ended up with something like 180 or 180 cases, and by the way, almost all of them co-infected with HCV. So pre-exposure prophylaxis and post-exposure, non-occupational post-exposure prophylaxis. I think there's a lot we could do for both of these. Of course, the city has a couple of great big grants that have a pretty big focus on pre-exposure prophylaxis, and Joyce does a lot of work with pre-exposure prophylaxis, and quite a few other people do. There's a lot of room for growth, I think, as everyone knows. It's been fairly slow to get going. There's been a few very vocal opponents to it. So we can come back to that if y'all have questions. I could talk for a while about that. Syringe services programs. So this was actually not highly, so I've got them more or less in order of how they were ranked in our work with the HIV planning group, but except for this one, which was like way low. And I have to tell you, like, as we explored it, I think because we were on the cusp of passing the legislation for statewide syringe exchange.
It passed.
Yes.
It made it through both chambers. The governor could sign it. Everyone here should call him and be like, hey, sign SB 97 so anyone can start a syringe exchange in the state of Maryland.
I think the signing is scheduled, but I have to go look.
Oh,
yeah,
for
I
sure.
think it's on the schedule. Yeah. Because I think we're going to get the opportunity to go and like stand behind the governor when he does it. You know. Yeah, so I think because we had just had that discussion, and when we were doing that prioritization, it was before the end of the session, but all indications were really, really good. The health department was extremely supportive of this. I mean, this was my boss's boss's boss and his boss like testified on it. Like they did a nice big push. So I think that they didn't rank it that highly because they thought, oh, it's already taken care of, and I'm like, no, you got to tell us that we need to do it. But I think we understand that we need this as a prevention program. Behavioral risk reduction interventions, I think this is tricky because CDC has certainly moved away from those models because they're so hard to bring to scale. And yet, if we look at some of the issues that people are dealing with, then sort of how do we find ways to bring those to a greater scale, and how do we find other funding to really reach some sort of saturation there? And then this is, I love this, HIV-informed systems integration. Just sounds great, doesn't it? But I think what we're talking about is a whole host of things. There's like a laundry list of things under that around cultural competency for providers and welcoming environments for people who are most likely to be impacted by HIV, and we're talking about HIV negative people, but housing problems don't happen after diagnosis or just after diagnosis. They're occurring before diagnosis, and a huge proportion of women with HIV report experiences with intimate partner violence, and men and women both report symptoms consistent with PTSD, and those exist before infection. They're not because of the diagnosis. So largely. So there's Ron Stahl has nicely laid out the path for gay men who experience violence and rejection as youth and go on to develop a host of risk factors, and moderate depression and anxiety are common both before and after diagnosis. So really understanding how we can promote those kinds of welcoming environments among a large set of service providers. In my experience, we would have, we had service providers who focused on HIV and might be able to, create a welcoming environment for young Black gay men or young trans people, but then the housing provider or the people who provided job training skills and things like that were not prepared for somebody to come in who was genderqueer, or somebody or a guy comes in with his purse, and So I mean, it's really important. It's like that you experience that rejection or just an eyebrow, and people don't come back. So that's some of that. And then condom distribution and promotion still on here. Condoms still work, still important. So I'll move on. Sorry, gotta keep going. Diagnosis sounds like it's simple, right? It's routine testing and partner services and targeted testing. Well, we have a long way to go to sort of get testing really routinely embedded in medical care. I think especially in Maryland, my experience was like we, had a law right as I got here. They were working on a law and passing a law that's to try to clarify appropriate consent processes. And for a long time, HIV was separate and different, and we're trying to mainstream it now so that that mainstream medical care will address it and test for HIV. And again, it's very important when we think about the number of people who sort of seem to avoid testing or not understand their risk, either because they don't understand risk or because their risk is not evident to them. It's not apparent what their partners were doing, or risk that occurs just from the background prevalence of HIV in your community or in your network, right? So we have I think a big opportunity to promote routine testing, and there's other funders out there. Gilead is very interested in testing people and identifying people and getting them on, any drug that works, I'm sure. So they've got money in routine testing, and but there's a lot that we can still do. HIV Partner Services, this is core public health activity. We really believe in it, and it's got a pretty high positivity rate, but it's also very intense, and there's still a lot of intensive work, and there's still a lot of room for improvement. Nobody knows what Partner Services is until they get that call. Does everybody understand what Partner Services is? It means like if you get diagnosed with syphilis or HIV, then somebody's gonna sit you down and say, so who have you had sex with? And we will contact them and confidentially notify them about their exposure and get them to test, right? And nobody knows what that call is until they get it. I think they're like, what? And particularly I think with the history of gay men and sodomy laws and things like that. It's like, I'm not going to report somebody who was breaking the law by having sex with me. So I think we're still dealing with that as a cultural phenomenon, even if it's not on the books or true anymore. So there's a lot that we can do to both promote the understanding of partner services from clinicians and from the likely recipients of partner services. There's also a lot we can do of our partner services staff around how do you approach somebody, and you have to be pretty aggressive as a disease investigator, right? But so how do you find that line where you're building rapport but being aggressive enough to get that information from people, and not viewing people necessarily as recalcitrant, but rather dealing with their own stuff, right? And then targeted testing, I have to say, we have some room to improve here. I think there's not that much. When I think of targeted testing, really we're talking about community-based, outreach-based testing. There's some in Baltimore. There's only a little, I think, in suburban DC, and suburban DC really represents a really a difficult, I think, part of Maryland when you're thinking about a couple of counties whose economic and social and cultural centers are outside of the district, outside of the counties, right? So they're oriented towards there. Some of them are getting services there. How do we have a whole lot of coordination issues to deal with DC in terms of data, understanding care patterns, and then responding to those care patterns or even prevention services seeking patterns. But still some work we could probably do there. So CDC came out with recently with estimates, state-by-state estimates of undiagnosed infection, and they said it was about 8,000 people in Maryland who were with HIV and undiagnosed. And we applied, so it's about 18%, which is pretty bad in terms of the rankings of the state. I think it was like second, in terms from the bottom. So when we apply that number to some of our own statistics, it's between 7,000 and 8,000 people probably. Now, we diagnose across the state, mostly in private practice, but across the state, we diagnose about 1,400 people every year. Oh, 5 minutes? Yeah. I'm almost there. So you should never promise that you're going to be quick and then not be quick. So I get myself going. If we're diagnosing 1,400 a year and we've got this reservoir of people with HIV, and it's like if it's 7,000 people, If we just want to get to 90% know that they're infected, 90% of people with HIV know their status, which is the national strategy goal, then that's about 3,500 people in the next 5 years. That's 700 more a year. That would be a 50% increase over the number of diagnoses we're making. That is huge. That is huge. So how are we going to move that? And I think that's why we sort of fall back to routine testing in terms of volume. HIV partner services is certainly super intensive, and network-based testing is a good strategy. But we have to get a lot more productive with it and do even more of it and do it faster, which means data improvements, things like that. I won't get into too much of that. So there's a ton of stuff here on care engagement. Linkage to care, we're doing a lot of trying to mine our surveillance data as well as other data. CRISP, I think, is a possible avenue for us to improve, looking at data and seeing who's in care and who's out of care, and actually doing some outreach to locate people and to bring them back into care, re-engagement. Expanded provider network. A lot of this is how we pay for services right now. Ryan White is a system. It shouldn't be. It's not a system. It's a payer. I think if it acted a lot more like other payers, we might have some more providers who would be willing to deal with the data requirements and the grant management requirements. But it's a little bit over the top right now in terms of those requirements and managing grants. Care coordination, I can't even start if I've got less than 5 minutes. Peer support networks, again, this culturally competent workforce, but really thinking about care environments and what does a welcoming environment really look like? How much are we asking clients to fit the system versus systems to fit clients? I think we have some introspection and reflection to do on that. And of course, health literacy. Viral suppression, we've simplified this somewhat from where we started. It's really about access to medication and then adherence strategies, a lot of which goes back to health literacy about what do these drugs do in my body, and why do I want my viral load to be low and my CD4 to be high. Access to medications, well, we spent about $30 million on access to medications already, so I think it's pretty important. We want to keep doing it. Health literacy is also in this day and age, we have it down here too. It's about use of insurance. 80% of our clients on the AIDS Drug Assistance Program, we actually support co-pays or premiums or both, and really understanding how to use insurance. And plus, we've transferred a whole lot of clients to Medicaid. We have more people on Medicaid with HIV, so and they're in managed care plans. So how do they best use their insurance? So if we took the votes and some of the work we've done around prioritization, these would sort of be our tier 1 strategies. Tier 2, there's the very long list. And we didn't really look at breaks in the data for the votes or anything, just sort of say like 30 or more and 20 to 30 and stuff. And then tier 3, a few things that we don't want left out, but perhaps are not where we're going to ask people to focus. So that is the entire presentation. Open for, I don't know how much time we have for questions and discussions at this point. But
I think we have the room for a little bit. So
okay.
They have to go to class, but we can
Class.
Class.
You don't have to go to class. I'll write you a note. Thank you very much. Any questions?
I was so interested you brought up the school system. What's your sense of, are teenagers learning about PrEP in school?
Oh, no.
Not happening yet. Okay.
No.
No, not even close. Okay.
No, I don't think people are learning about it. I think there's a profound level of ignorance around HIV, and we forget, and about sex and sexuality in general. It's extreme. Yeah, I come from Texas, so maybe I'm biased, but it's worse there, I'm sure. But
I was actually interested in that subject as well, because I've seen that just about 25% of Baltimore schools are LGBT inclusive with their sex ed curricula. And I'm curious, how's that going when you approach local school systems? Are they receptive?
Well, I don't know, because we haven't done it yet. So that's in our plan, but that's definitely, I think that's one thing that I didn't talk about is that some of these things that we've been doing, we've been doing care coordination for a long time. I think we can do it a lot better. But in terms of mobilization and truly, rather than sitting around and saying like, oh, the State Board of Education should do something, actually training advocates to have those local conversations more is not something we've been doing. So I mean, I'm excited about trying to do that work. But it's a big hill to climb too.
Just along those lines, for anyone who's interested in that area, I worked with on passing CPR as a high school graduation requirement. It's very logical. We were opposed by the Board of Education because they do not want anyone talking to them about curriculum, and it's a huge fight. And at the same time, I was shopping in Talbot's to buy a jacket for an HIV event we were going to, and the gentleman who was helping me said, oh, what do you do? Because I was told him he said, can you tell by looking at me if I have HIV? Do I have HIV? I mean, this is a high school graduate as I start talking to him, and it's just so incredibly frustrating. So please, help take this on in any way possible, and I think it's really important. But it has to be very local because the health of the school board is not going to help you.
No, and I mean, there's a tradition and a real desire for local control over schools and curricula, and that's actually a leverage point. Like you're not like moving the whole system could be harder, but there's 25% of schools. Then like there's your champions. We've actually already got all the early adopters on, so you're just looking at a diffusion of innovation curve that you just have to get over the hump.
Hi, I'm a nurse and I did a degree in public health and I worked in HIV/AIDS about 10, 12 years ago. I've been away from HIV/AIDS for about 12 years, just coming back into it. My concern is you reported about 8,000 undiagnosed people in Maryland, so they're just people that don't know they had HIV. Comparing what I did and what I kind of saw at 10, 12 years ago and what I see now, I don't know if it's just my perception, but I just don't feel like there is enough, I guess, social media or just social marketing or attention to HIV/AIDS. Yeah, it's a responsibility of providers to say, hey, when you get tested, probably get tested, when you go to a gynecologist, you need to do it through those routes. But just in general, I don't see commercials about condoms. I feel like maybe I do, maybe I don't. I don't see anything. I'm a woman, I'm a nurse, I'm health conscious. I get tested, I do it because you should do that. I don't care about HIV/AIDS, but I still get tested. Because I feel like it's my responsibility, but I feel like other people that are not in health and not in public health or nursing need to get tested. I just feel like there's not anything, we don't hear about it. It's almost like it went away.
Mm-hmm.
They hear, oh, a person has HIV, they got AIDS, or a celebrity has AIDS now.
Yeah,
oh,
Charlie Sheen.
AIDS is still here? Oh, really? Oh.
Yeah.
People are still getting infected? Oh,
I mean,
heard about it.
when I talk about
Johnson, Magic Johnson, I think that was years ago. But I'm telling you, like, because I've been out of the scene for so long, I've been in the maternal child health, and the only time I hear about it is somebody, a patient that's HIV positive, and pregnant.
Yeah.
And it's just really sad to me, and so I just think we don't know about it. We know about Zika, we know about the Flint, Michigan water crisis, and I don't hear about HIV, and it's so sad, and it's like, we need to do a better job of awareness.
Yeah, I mean, I agree. I think that marketing for general awareness, came up really big. And I mean, I talk to people about what I do, and they say, "Oh, is that still a thing?" I'm like, "Yeah, it's still a thing." So definitely, if people are outside of the field, nobody knows that there's a national strategy except for people who work in it. Like, oh, hey, there's a national strategy. So, your average person isn't there. Yeah.
So Jeff, thank you for that talk. Question I have is, what is the process by which you're going to tailor the plan for different jurisdictions like Baltimore City versus Prince George's, so what is that process? And then how can people contribute if they would like to? How can they inform or help in any way?
So I should have anticipated those questions. I think that we've been wrestling with exactly how to, where in the plan to sort of call out different regional differences. I think that, to be honest, we talk a lot about how do we reflect, how is the plan going to reflect Baltimore? Our challenge is for it to reflect anywhere but Baltimore, because most of our input, most of our information really does come from Baltimore. We're about to travel around the state. We've done some big, broad engagements, but we're about to travel around the state with the basic framework and try to get a little bit more input. I do think we know from previous work a lot of the, a number of the rural areas all sort of suffer from there's a smaller population. There's a lower level of infection, but there's still people who need services, and then there's just a really, really small infrastructure to deliver those services. So then how do we respond to that? So I think that's the one of the biggest things. One of the things that we've talked a lot about in Baltimore is medical mistrust, and talking about how we create coordinated care with different funding streams and things like that. A number of, again, the party council has done, I think, a good job of holding a number of forums to give input. Thank you, Carlton. In terms of, so I feel like we'll do a good job of, this is a 30,000 foot view maybe, so, it's not really about SMART objectives and annual goals, but so some of that comes in some of the implementation planning and the operations of the plan, but I think we'll be able to characterize it a couple of different ways to participate. You can submit an application for HIV planning group and come to the planning group. Baltimore has a party council that looks at services and the commission, so you can participate on those. And I don't think we have any other forums scheduled at this point in terms of more input, but as we get a little bit more flesh on the plan, we should be over the summer putting that out for comments, and then we want to, so our federal funders require a submission of a plan in October, and we should wrap it up by September, and get something done and say, okay, here it is, and then we can start with stage 2. So
I'm a provider and a researcher focused on young adolescents, HIV. And my question is, there's so much fluidity, with we talk about DC PG, but DC Baltimore, we have lots of kids who are really moving. So wondering what is in the plan about coordination with all the health departments. I have some experience in that, just curious what this can be.
So we haven't written a whole lot of specifics about that into the plan, and there, there's been some argument within the health department. Is that our issue to talk with each other and deal with, or do we put it in the plan? And I want to put it out there in the plan as you can't really get to some of these things without a deeper level of coordination. We're definitely already on the path. So I have a really good relationship with Patrick and some of the other people at the city. No, all the people at the city. I think we have a better relationship than we've had before, and we're all of one mind. Sometimes the turf comes up, but we have a good relationship with DC. We have there's some particular issues with data flowing across the DC and Maryland border that I think we're close to solving. Actually, we've got some data sharing around surveillance data that will help us. The partner follow-up data sharing. Like right now, you have to this person's in DC, so I've got to refer it to DC, and then DC has to investigate, and then DC has to get back to me. And so we're still trying to work out some of those that I think can improve that coordination. But a big part is what we're working on right now in Baltimore and Maryland is a unified data reporting system for care services that will also necessitates one standard set of definitions, because believe it or not, they're not quite the same, and really unifying reporting and management standards so that you don't have to say like, oh, this person's eligible for, I have money for this service from Part B, but he's over 300%, or whatever, like you don't have to have a grid to figure out like what can pay for what. You can more seamlessly braid your funds, which is huge, I think, for providers. And be able to easily report it in one place. And a reporting mechanism that people can abstract from their EMR and push into our data system. I think, the boutique data reporting is over.
Is there, in the plan, or will there be plans to how you will operationalize, the sort of, you outlined the
Sure, yeah. So what are the, so we're like sort of like what are the major steps to get there? Yeah.
the specifics.
Oh, yeah.
And like, as part of that, just an inventory about who's doing what.
So one of the requirements, and I think it's a requirement for the plan anyway, but is sort of a resource inventory, and that's not. Sometimes people do resource inventories and they're like, oh, well, a guidebook of every resource you get. No. Our resource map is really, and we have a lot of work to do on it, but is charting all of the money coming into the state and sort of what are its boundaries. What activity is it for, and what is its geographic focus, and a little bit around population focus. So that's a huge part of putting this together, and yeah.
And that would be in the plan also.
Yeah, it'll be
So Jeff, thanks so much for this. I guess the question that follows on to that a little bit is about the costing for the plan. Do you think there are additional resources needed to reach the goals in the plan, or?
Costing the plan is a really not something that we've thought a ton about. I think some of it comes around to particular restrictions on funds. So you have federal funding that will pay for care but not prevention. So and prevention but not care. So PrEP. NPEP have NPEP for a very long time, and PrEP has been a big gap in terms of what we can pay for, right? Because HRSA gives us money to pay for care almost exclusively for people who have HIV, right? And then CDC gives us money for HIV prevention, but we can't buy drugs with it. So here we have an intervention that is a drug, an HIV drug, for an HIV negative person, and it falls in a gap between the two funding streams, and that's been a real problem. We've developed some financing mechanisms for at least for the next few years will help us pay for that, and I think it's aggressively interpreting some of the federal guidance that helps you get there sometimes. Costing out some of the things like media, like what would it really take to get saturation on the media? I think that is definitely something that we should do. Yeah.
Thank you so much for coming.
Yeah.
I think that, as we've been meeting with CFAR and I've been involved in the plan discussions, it seems like there's a real opportunity for some of the research resources here and objectives to come in line with what's going on with the plan. And again, these sort of specific interventions, how can CFAR be a part of that?
Yeah, I have a number of research needs. I'm trying to keep the list in my head, so I'm hoping we get to that discussion in a second. Yeah.
Lunch.
Yeah. All right. Thank you.